Dr. Sadiq. And I may add few points as a cardiologist because this is very difficult situation, as you know. Uh, Actually, in addition to what Dr. Sadiq said, usually in this very difficult situation, we prefer unfractionated heparin because if the patient bleed, you can withdraw it early on, and actually the half-life is not long. And the problem is that if you have a mitral valve prosthesis, this is very difficult situation rather than the aortic valve prosthesis because mitral valve is very thrombotic because mitral valve lie between chamber and chamber. The mitral valve lie between the left atrium and the left ventricle. And here the flow is not high because flow like a venous system because the left atrium is actually a vein, a modified vein. And here thrombosis the chance to develop thrombosis is very high. So we don't like to stop anticoagulation in the mitral valve prosthesis for a long period of time, usually not more than a few days, maybe up to 7 days. But when you concern the aortic valve, here the flow is high because the aortic valve lie between the left ventricle and the aorta. And the aorta, the left ventricle, actually the modified artery. So you have a valve here between the arterial system and the flow here is very high. The chance to develop thrombosis here is not high like the mitral valve. So our target INR when you put the mitral valve prosthesis is 2.5 to 3.5. But if the patient develop thrombosis in spite of this INR, you go for a higher INR, maybe 3 to 3.5 or 3 to 4. And the INR in the aortic valve, the target INR is 2 to 3. But if the patient develops thrombosis in spite of this target INR, you go for higher INR 2.5 to 3.5. And the American guidelines add aspirin in addition to warfarin in these patients. This is in contradistinction to the European guidelines. Usually they give only warfarin, but aspirin in the American guideline was class 1, but nowadays it is draw down maybe to 2A rather than 1. The other problem, Dr. Sadiq, here, when you have a clear indication for anticoagulation, for example, you have a patient with atrial fibrillation and they develop stroke, and you have a major stroke. Usually the question is the time to start anticoagulation in such patients. Please, if you can declare more in this point.
It's a good question. Thank you for your insight. Yeah, the patient I was talking about was a mitral valve, actually, with a big thrombus. That's a great point, and thank you for adding that. So the question about when to start anticoagulation or when to restart anticoagulation for patients coming in after ischemic stroke, and this is a common scenario because they would have their anticoagulation held for a colonoscopy or for a procedure, or they for financial reasons, etc. And so, or poor compliance. And then they come to you with ischemic stroke, and then like to decide when to restart anticoagulation. And again, your size of a stroke is a big determinant to when you start anticoagulation. There is data supporting that you can start as early as, so obviously if you have a very small infarct, you would start like within a day or two. In the past, we would use a rule of like a mild infarct, moderate infarct, or sizable infarct. Sizable infarct, in the past, we would wait 10 to 14 days and then do a repeat scan. If there is no hemorrhagic conversion, you restart anticoagulation. Nowadays, we are leaning more towards starting anticoagulation early. like even less than 7 days after having an ischemic stroke. And your determinants would be like your size of ischemic stroke and whether there is any hemorrhagic conversion. If you don't have any hemorrhagic conversions, you could start as early as less than 7 days. If you have a small stroke, you could start like within 2 to 3 days. There is no like solid number that you would rely on. It is really dependent on the judgment of the size of the infarct and the absence of hemorrhagic conversions.
Dr. Sadiq, I think you have a different guideline. Last time I reviewed the European guideline for minor stroke and TIA, as you said, they start anticoagulation in 3 days. For moderate stroke, 6 days, and for major stroke, 12 days. It did change, or you have a different guidelines?
Well, it did change, but it's not incorporated in the guidelines. But there is evidence in the literature that you could start as early as 3 days with no significant risk of difference in the risk of hemorrhage.
Okay, thank you very much. Please, more questions?
السلام عليكم.
عليكم السلام،
عليكم
تفضل.
السلام.
طيب, being sorry for joining late. I think we missed an interesting topic. Thank you very much, Disugi, for your efforts. My question just to Dr. Sadiq, although I did not attend it from start, but still the question which is remaining in my mind: what is the best modality to start or to immediately differentiate between hemorrhagic and non-hemorrhagic strokes in the acute phase as to start the therapy, if you don't mind?
In terms, thank you. I think sorry, imaging modality. You mean, right?
Yeah. Imaging modalities. Whether MRI, CT scanning, or.
Oh, right. Okay. So the workhorse really for acute ischemic stroke is the CT scan. Readily available, and actually most guidelines state that you need to image your patient within 15 minutes from arrival. You have also the option of doing a CT angiogram. You have the option of doing a CT perfusion. And then all of those, like your non-contrast CT scan, your CT angiogram, your CT perfusion, the three modalities helps you with your decision making about whether you thrombolize, whether you extend your thrombolysis window, or whether you take patients for mechanical thrombectomy. So the workhorse for acute stroke management is CT angiography, all the three modalities: CT brain, CT scan with all the three modalities: CT brain, CT angiogram, and a CT perfusion.
Thank you very much, Dr. Mahdi.
Thank you, Mahdi. Mahdi Usman, مش كده?
Yes, Mahdi Usman Said. Thank you very much for joining us. Actually, Dr. Sadiq, usually, and I remind my young colleague here in the practice, we have secondary stroke treatment and primary stroke treatment. And actually, what we discuss is the secondary stroke treatment. And it is very sad, Dr. Sadiq, here, the primary stroke management in this country is not well implemented due to many factors. Usually patients come late, and also it is not well established treatment here due to a lot of things. Can you declare? Can you have more information on the primary stroke management so as to conclude this session? Thank you very much.
So I think for acute stroke management, we can always, like in the past, like most of the talks I gave were about acute stroke management. Actually, I think in Ulubayt, you can readily get a CT scan, right? I mean, like the CT imaging is available. The question would be like public awareness and then drug availability. We had the ACT trial that is non-inferior to alteplase. And I know that TNK I think it's available in Sudan, or is it not, at Disugi? You use TNK, right? For thrombolysis.
available. It is available, but usually the primary stroke management or acute stroke management or thrombolysis is not well established in our minds. Usually people rush to aspirin and clopidogrel and this form of treatment. What I mean, why not to implement primary stroke treatment and to have a stroke unit? We have CT, which is available, and we have tissue plasmid gene activator available in Al even. We have alteplase in Al.
Yeah. No, I think this is a great project, to be honest. Developing a stroke unit. I think it's a great project because if you think of the pillars, as you said, you have the CT availability, you have the manpower, you have the physicians, and you have the interested internist and cardiologist, and you have your CT imaging. So I think and Mustashfa Daman is well equipped. So I think this is I'm very happy to help. If someone who is going to take the lead for such a project, like someone is going to say, okay, because these projects you always needs a chaperone, someone who would say, okay, I'm going to take the lead for this project, and then you take all your colleagues to help you with this, including everybody. You need your medical students, you need everybody to increase stroke awareness. You need to do a fast campaign. You need to talk about your pathway. You have to develop your pathway about, okay, the code stroke is activated. Who is your primary contact? And you need to act fast to treat your patients within the time window. So as I think it's very doable. I'm not going to say that we do CT angiography and start to talk about mechanical thrombectomy, but I mean, you have to start somewhere. Like if you start with um, having a stroke unit and then you start to implement thrombolysis, and you slowly start to build up on that and improve your care, right? I think that's a great project. Disugi and colleagues identify someone who can be a chaperone, and then I can work with whoever would like to take this project forward.
Okay, thank you very much, Dr. Sadiq. Actually, here in Daman International Hospital, we discuss this and some arrangements and the plans, and we are going to have it soon, inshallah, with your help, Dr. Sadiq.
Inshallah.
Any more questions? Okay, if we don't have questions, I have to thank Dr. Sadiq Ali Hassan Al-Amin. Very much thank you, Dr. Sadiq, for this elegant talk, and thank you for your time. And actually, we need more sessions and more discussions in neurology and in stroke, inshallah, in the coming few weeks. Thank you, our colleague who joined us through Zoom, and those who are here in the room. Thank you very much. Thank you very much, Dr. Sadiq.
شكرا دسوقي، والله احنا بنشكركم انتوا الناس القابضين على الجمر والقاعدين وشغالين في الظروف دي، والشكر لكم انتوا الشغالين رغم المسيرات ورغم المصايب والبلاوي، ونسال الله ان ربنا يقويكم، ونحن available ان شاء الله for help. وانا as I said ان شاء الله باذن الله ممكن اتكلم مع السكرتير القديم للنغابه هنا، وان شاء الله يعني حتى talks in different disciplines. Also, if you need me to talk to a guest speaker, and if you need one of the cardiologists here to participate, I'm happy to talk to them.
Thank you very much, Dr. Sadiq. This will be great. Inshallah, I will arrange with you. Thank you very much, and we have come to the end of this session. Thank you.
شكرا دكتور الدسوقي، شكرا دكتور الصادق، بارك الله فيك.